Okay, so hello everyone, good evening, and welcome to yet another meeting and learning experience from the ASG Academic Cell. So the main purpose of this ASG academic cell is not just to train fellows, but also to organize and spread on the knowledge that we have from various faculty across the globe, and to make it easier access and so that we can learn from them. So I welcome you on behalf of the academic cell to the session number 20, and we have a guest speaker today, Dr. Enrico Borrelli. Uh, so just in brief about the academy itself, from around 2022, this exercise was started, and we had esteemed doctors, faculties across the globe, like Dr. Singul Osdek, Professor MZ, Dr. Barbara, over a period of time, Dr. Ahmed Salam, Dr. Rajiv Muni, and many more talking about Dr. Pramod Bhente, Dr. Jeevan Tityal, over a period of time. If you look at the lectures, the list goes on. And most importantly, we have all of these lectures on our YouTube channel. Dr. Avinash Patange, Dr. Mahesh Shanmugan, Dr. Parveen Sen, Dr. Atul Dhawan giving us a very wonderful talk on macular hole. So, with this, yeah, quite a big list of good, interesting lectures. Dr. Saurabh Patwardhan and Dr. Omar again. A few of our faculty were so good, they liked it that they want to take repeat lectures for our faculty as well, for the panelists. Recently, we had a wonderful lecture by Dr. Ahmed Salam on a few weeks ago, and on vitreoretinal interface disorders. And to continue that, today is a session 20 where we have Dr. Enrico Borrelli with us, and our topic is age-related macular degeneration. So, Dr. Enrico Borrelli, as all of you know him, is Associate Professor of Ophthalmology at Doheny Eye Institute in UCLA, and he's done his ophthalmo residency from San Rafael and a research fellowship in retinal imaging again from Doheny Eye Institute. He is also not just a clinician but a researcher par excellence. He has done his PhD in ophthalmology and visual sciences, and that helps him to understand the research perspective as well. He specializes in advanced retinal imaging, OCT, OCT angiography, ARMD. Apart from ARMD, even pachychoroid spectrum and inherited retinal disorders as well. He is an avid publisher with over 330 publications in leading journals. His important work is in emerging biomarkers for the prognosis and therapy. Uh, Apart from publishing, he also enjoys being on the editorial board and giving suggestions to other researchers across the globe as well. For this, he has received multiple international awards, and his pioneering work is in retinal imaging, is mainly to bridge the gap between the research and the clinical practice. So this transnational work which he is doing today, we are happy to have him on board, and we ensure that all of us have a wonderful time learning from him. So with me, my colleague Dr. Jayant uh, will be helping us moderate this session, and he'll present a different perspective than what I bring to the table. So over to you, Dr. Jayant.
Yeah. Thank you, Dr. Bhavik. And
Yeah, so just a brief note, Dr. Jayant is a senior retina consultant, and recently he has also received the ASRS award for his multiple surgeries and all, and is a
doc
clinical par excellence.
yeah,
Yes,
yeah.
Dr.
And
Jain, yes.
Dr. Bhavik am I audible, Dr. Bhavik?
Yes, you're audible. We'll
Yeah.
go ahead with the panelist, Dr. Jain, yes.
Okay. So we'll now, it's my honor today to introduce our very esteemed panelists. We have five very senior and renowned vitreoretinal surgeons from around the globe. To start with, I would like to introduce Dr. Mona Bende, ma'am. She is a senior consultant and director at Sri Bhagwan Mahavir Vitreoretinal Service Medical Research Foundation, Shankar Nethralaya, Chennai. She is a fellowship-trained vitreoretinal surgeon, having over 3 decades of experience in managing medical and surgical vitreoretinal disorders and training ophthalmology residents and fellows in vitreoretinal surgery and medical retina. She has 120 peer-reviewed publications, one of which was awarded the AIOS IJO Platinum Award. She has also received the AIO's Rima Mohan Award and IGO Peer Review Award. Her special interests are retinal imaging and inherited retinal disorders. She is a member of the Macular Society, Vitreoretinal Society of India, International Retinal Imaging Society, and AIOS. Can we go to the next slide? Yeah. So next we have with us today Dr. Maria Vittori Cincinnati. She is an assistant professor of ophthalmology at the University of Vita Salute San Raffaele, Milan, where she did her residency in ophthalmology. She later did her fellowship in medical retina and uveitis at Northwestern University, Chicago. She is the recipient of ICO Allergan Fellowship in 2020, Macular Society Research Grant in 2023, AAO Secretariat Award in 2023. She has more than 220 peer-reviewed publications and book chapters. She is also the editor of Ultra-Widefield Imaging Retina of the Retina and editor-in-chief of American Journal of Ophthalmology International. She is also an associate editor of multiple index journals and a member of Vision Loss Expert Group. She has national scientific qualification for associate professor in Italy and has been an active mentor and trainer for residents and medical students. Can we go to the next slide? So our third panelist today is Dr. Rupak Roy sir. He is a senior consultant at Vitreoretina Services, Shankar Nethralaya, Kolkata, and a faculty of Vision Research Foundation. He was a gold medalist in his Masters of Surgery Ophthalmology at RIU Kolkata. He has published extensively in peer-reviewed journals and been a contributor to various book chapters in retina and uveitis. He has had an active involvement in clinical research trials at Shankar Nethralaya. He is a member of editorial board of Indian Journal of Ophthalmology, a regular faculty and invited speaker at various national and international ophthalmology meetings. He has been a recipient of awards from All India Ophthalmological Society and other professional bodies. He had also received the Best Poster Award for Retinal Detachment in Morning Glory Disc Syndrome at the 45th Annual Conference of Ophthalmological Society of West Bengal in 2014. Next, we have Dr. Alberto Quatta today. He's an ophthalmology resident at SS Annunziata Hospital in Chieti, Italy. He has done his MD from the same institute, and his early research he has done at IRC San Raffaele Hospital. He has had specialized training at ESASO Lugano in cataract and vitreoretinal surgery. He has had publications in prestigious journals like Retina, British Journal of Ophthalmology, and many others international journals. His focus on research has been about retinal imaging, macular disease, vitreoretinal surgical innovations, and choroidal biomarkers. He has presented multiple times at URetina, ARVO, Fluoretina, and SISO. And he has also had ARVO Knights Templar Eye Foundation Travel Grant Award, Best Mystery Case Award, and Favaloro Award in 2024. And last but not the least, we have Dr. Daraya Shroff, sir. He is a senior consultant, medical director, and head of the vitreoretina services at Shroff Eye Care Center, Delhi. He has been a pioneer in adoption of advanced retinal imaging in India and has more than 70 peer-reviewed journals authored and textbook chapters authored. He has been a regular faculty at AIOS, VRSI, URetina, ASRS, and various international meetings, and has been involved in various clinical research and multicentric trials. He has been a recipient of multiple Red Buckler Awards at ASRS, and he's also received the Best Video Award at the 25th Annual VRSI Conference. He has also got IGO Award for peer review and has multiple contributions in the field of vitreoretina in India. So with that, we now would like to request our guest speaker today to start with the discussion on ARMD, and we are all are ready to listen to you, sir. Over to you, sir. Dr. Borrelli, you can share your screen. Yeah.
Yeah, I'm gonna share my screen. Before starting my presentation, I would really like to thank everyone for this opportunity. I would also like to thank the panelists for taking the time to be here and to discuss on age-related macular degeneration, which is a very important disorder. So it is very helpful to better discuss on this disorder, on the new available treatments, and also on the imaging biomarkers we may want to use in this kind of disorder. So these are my disclosures, and so before starting all the staging and all the features of age-related macular degeneration, it's important to remind everyone that AMD is a very common disorder and is the leading cause of irreversible blindness in older adults. So it is a common disorder, and the prevalence of AMD is also expected to increase in the next few years. So it is very important to improve our knowledge of this disorder. AMD may be classified into different stages. Early or intermediate AMD are mainly characterized by the presence of drusen or pigmentary changes, while late AMD may be characterized by the presence of geographic atrophy or a macular neovascularization. So I'm going to start with the clinical case. This is a patient complaining of reduced visual acuity in the left eye. This is the fundus photography showing the presence of reticular pseudodrusen in the right eye, and also the left eye was actually characterized by these lesions. And when we look at the left eye, it is quite easy to detect the presence of this foveal hypopigmentation. So in these cases, it is always important to use fundus photography with other imaging modalities in order to better characterize our patient. In the left eye, we were able to also perform structural OCT showing the presence of this hyper-reflective lesion where the reticular pseudodrusen were located. And sorry, I will be back to the slideshow. And in the foveal region, there is this hyper-reflective material which can be associated or not with the presence of a neovascularization. So we did perform also OCTA showing blood flow overlapping structural information. And you can clearly see that in the hyperreflective region, there is no evidence of flow right here in this region. So this was a case of intermediate AMD. Non-neovascularization was affecting this patient. And in addition to drusen, this patient was also characterized by other lesions, including reticular pseudodrusen and subretinal hyperreflective material without any evidence of neovascularization. This is another case. Also, this patient was affected by intermediate AMD, both eyes, and you may appreciate this large detachment of the RPE with some biomarkers associated with a more likely progression to late AMD, including the presence of this hyperreflective foci. After 6 months, the patient was still characterized by this large drusen. However, other biomarkers were visible using structural OCT, including hyperreflective foci and this hypertransmission defect. When we compare the drusen volume in between 6 months and baseline follow-ups, it was evident the increase in the drusen volume over time. And after 15 months, this patient was actually characterized by the development of a region of atrophy, which was even larger after 2 years. So this was a patient with intermediate AMD developing geographic atrophy, developing late AMD, And when this patient was affected by intermediate MD, some biomarkers associated with progression were visible using structural OCT. And it is always important to detect biomarkers associated with the greater progression to late MD. When we see patients with intermediate MD, there are different biomarkers associated with progression. Most of these biomarkers may be visualized using structural OCT. These are the most important biomarkers. One of the most relevant biomarkers is the drusen volume. So when you have a patient with intermediate MD, you may want to measure the drusen volume, as a greater drusen volume is associated with a more likely development of late MD over time. Another important biomarker associated with the progression from intermediate to late MD is the presence of reticular pseudodrusen, as in our clinical case. Reticular pseudodrusen may be visualized using different imaging modalities, including structural OCT, where they are evident as small hyperreflective lesions just below the neuroretina. There is another important biomarker associated with a more likely development of late MD, which is the presence of hyperreflective foci. Hyperreflective foci may be easily visualized using structural OCT, and they are usually associated with the presence of hyperpigmented regions in the macula of our patients with intermediate MD. There are other biomarkers. This is another slide on hyperreflective foci, just to remind everyone that not only the presence of hyperreflective foci, but also the amount of hyperreflective foci is an important biomarker of progression from intermediate to late AMD. Our patient in our clinical case developed an hypertransmission defect, which is another important biomarker in patients with intermediate MD associated with the development of GA over time. In these cases, you may want to use a slab just below the RPE to highlight the region with hypertransmission defects. And this can be useful to detect and quantify the hypertransmission defect into the choroid when we want to understand the risk of progression from intermediate to late MD in our patients. There is another important biomarker associated with the progression from intermediate to GA, which is the presence of basal lamina deposits. They can be visualized using structural OCT, as they can be visualized as a flat detachment of the RPE, as in this case, this is Bruch's membrane. This is the hyperreflective line corresponding to Bruch's membrane. This is the RPE. You can see that there is a detachment between the RPE and Bruch's membrane, and in between these two hyperreflective lines, there is some hyperreflective material, which is associated with the histological evidence of basal lamina deposits. There are other biomarkers, including changes in the outer retina. When we look at the OCT, we may want to detect the presence of changes in the ELM or a ellipsoid zone, or also a thinning of the outer nuclear layers. All these changes are associated with a more likely development of late MD in patients with intermediate MD. Finally, as in our clinical case, there is another important biomarker associated with the progression from intermediate to late MD, which is the presence of this pseudovitelliform material. This material is not uncommon in patients with intermediate MD, is usually associated with the presence of reticular pseudodrusen and is an important risk factor for the development of GA in patients with intermediate MD. So let's go back to the staging of AMD. In patients with early or intermediate MD, it is important to detect the different biomarkers associated with the progression from intermediate to late MD. But let's see when we have a patient with late MD. This is a patient complaining of a reduced visual acuity in the left eye. You can see on fundus photography some changes in the macula. In the right eye, where the patient was not complaining of any change in visual acuity, only drusen were visualized using structural OCT. But when we moved to the left eye, which was the eye with the reduced visual acuity, we were able to detect this fibrovascular PED associated with some subretinal fluid, interretinal fluid, and there is also some subretinal hyperreflective material in this patient. So this is a case of neovascular MD, and this was confirmed using OCTA. On OCTA, you can see that the hyperreflective material in between the RP and Brooks membrane is associated with some flow, some red flow on OCTA. And when we look at the unfast image, you can clearly see a large type 1 neovascularization. So this was a case of neovascular exudative AMD. This is another case. Also, this patient was affected by, was complaining of a reduced visual acuity in the left eye. In the left eye, you may appreciate this hemorrhage close to the fovea region. And when we perform structural OCT, this patient was also had also evidence of intraretinal fluid, some subretinal fluid, and this hyperreflective lesion. And when we perform OCTA, some flow was evident within this hyperreflective lesion. So this was a case of type 3 macular neovascularization in neovascular MD. So in any case, with evidence of neovascular MD, it is important to define the type of exudation and the type of neovascularization. There are different types of exudation. The one type of exudation is the presence of intraretinal fluid. Intraretinal fluid is usually associated with the worst prognosis in patients with neovascular MD, except for the patients with type 3 macular neovascularization. The most common type of exudation is the subretinal fluid. This is detected in almost 80% of our patients with neovascular MD at baseline, and it is usually associated with the good prognosis in patients with type 1 MND. Another important type of exudation is the subretinal hyperreflective material. The subretinal hyperreflective material is an OCT sign which can be associated with different types of lesions, including blood, fibrosis, or the presence of a neovascularization. In this case, type 2 macular neovascularization. As I mentioned previously, it is always important to define the type of neovascularization. There are 3 types of neovascularization, including type 1, type 2. Type 1 and type 2 originate from the choroidal vessels, Type 1 is located below DRP, type 2, while type 2 is located above DRP. Type 3 is another type of neovascularization, which is quite common and originates from the retinal vessels rather than the choroidal vessels as in type 1 and type 2. So using structural OCT, we may be able to detect the type of neovascularization. Type 1 is usually characterized by a fibrovascular PD, and it is usually evident some subretinal fluid. Type 2 is usually associated with the presence of subretinal hyperreflective material on structural OCT. In type 3, intraretinal fluid is present, and it can be associated with the large serious PD. But it is important to define the type of neovascularization. So let's say that we have a patient with neovascular MD. In this patient, for sure, we are going to start our treatment with anti-VEGF therapy. It is important before starting our treatment to define the type of neovascularization. I will suggest that this is important for a number of reasons. The first one is that the same fluid location may be associated with different outcomes based on the type of neovascularization. As an example, subretinal fluid is associated with a good prognosis in type 1, while is consistently associated with the worst prognosis in type 3. Type 2 is usually more commonly complicated by macular fibrosis, while type 3 is quite commonly complicated by macular atrophy. So based on the type of neovascularization, you may predict the development of macular complications. However, making a diagnosis of type of neovascularization is time-consuming, and it also requires some expertise. And because of this, probably in the future, there will be some deep learning-based algorithms that may help in this specific task. In this paper, we did develop an algorithm which was able, with a very high sensitivity, to differentiate the different types of neovascularization. So in patients with neovascular MD, it is always important to start our treatment with anti-VEGF, and blindness because of AMD has reduced over time. And this reduction is because of the introduction of anti-VEGF. Anti-VEGF treatment has significantly changed the prognosis of our patients with neovascular MD. This is the history of anti-VEGF treatment in patients with neovascular MD. The first treatment was introduced in 2004, and in 2022 and 2025, the last two second-generation treatments have been introduced in the market. This is just to highlight that since the introduction of the first anti-VEGF treatment, it was clearly evident that the prognosis of patients treated with this kind of treatment may improve over time. So it is very important to start our treatment with anti-VEGF as soon as we make a diagnosis of neovascular MD. There are different factors related to the anti-VEGF treatment. The first one is that it is very important to start our treatment as soon as possible when we make a diagnosis of neovascular AMD, as a longer delay is a significant predictor of worse treatment outcome in patients with neovascular AMD. So if you have a patient with neovascular AMD, it is important to put effort in starting your treatment as soon as possible. And this was really evident in the COVID pandemic, when we were unable to start our treatment right away after making a diagnosis of neovascular AMD, and patients starting treatment with anti-VEGF therapy during the COVID pandemic were more likely to have worse visual outcomes as compared with patients starting treatment in the previous years. So this is an important aspect to highlight when we speak about anti-VEGF treatment in patients with neovascular AMD. There is also another important point. In order to start our treatment as soon as possible, it is important to identify biomarkers associated with a more likely development of neovascular AMD over time. We have seen in the previous part of this presentation that there are different biomarkers associated with the development of late AMD, including neovascular AMD in patients with intermediate AMD. But another important biomarker is the definition of non-exudative neovascular AMD. There are some patients with new vessels without any evidence of exudation, as in this case, you can see there is no intraretinal fluid, but these patients had a thickening of the retina and this hyperreflective lesion. So we follow up on this patient, and after a few weeks, this patient developed intraretinal exudation. So this was a non-exudative type 3 macular neovascularization developing exudation in a few weeks. So if you are able to detect a non-exudative neovascularization, you may want to change the follow-up of your patient in order to detect the development of exudation as soon as possible and start your treatment right away. Another biomarker I would like to highlight is the presence of neurodegeneration. We know that patients with AMD are affected by some loss of the inner retina, and this was evident since the histology study, very first histology study, as in this case. You can see that in patients with AMD there is some migration and some loss of ganglion cells. And we are able to detect the neurodegeneration using structural CT. We may detect neurodegeneration by performing a peripapillary analysis of the retinal nerve fiber layer, as in this case, this is a patient with optic neuropathy, but this kind of examination may be performed even in patients with AMD. Or we may want to investigate the ganglion cell layer thickness in the macular region. And also in this case, also this is a patient with optic neuropathy. But again, this examination may also be done in patients with AMD. And we have made some studies in patients with AMD using the structural CT, and we were able to demonstrate that the neurodegeneration is common in patients with AMD since the early stages of the disease. So even in patients with intermediate AMD, there is some loss of the ganglion cell. And this loss is probably because of a damage of the photoreceptors leading to a post-receptor neuronal loss. So the photoreceptor loss may reduce the number of stimuli to the ganglion cells, this leading to a ganglion cell loss. This loss is greater in patients with late AMD, and there is a loss after the transition from intermediate to neovascular AMD. So we know that there is some neurodegeneration in patients with AMD. This neuronal loss is greater in patients with late AMD, and this can be clearly visualized using a structural OCT. You can see in this image the neuronal loss. But what it is very interesting is that neurodegeneration may be a biomarker of progression. In this study, we performed in collaboration with a group in Australia. We were able to demonstrate that in those patients with intermediate MD, the neurodegeneration may be a biomarker associated with the progression. So those patients with the greater neurodegeneration are more likely to develop neovascular MD over time. So this is just to highlight that we have a number of biomarkers associated with the progression from intermediate MD to late MD, and we may want to use these biomarkers to predict the development of neovascular MD and start our treatment as soon as possible when there is a development of neovascular MD. When we start treatment with anti-VEGF, there are different treatment regimens, including a fixed regimen and as needed regimen or a treat and extend regimen. One of the main concerns when we start treatment with anti-VEGF is that there is some inconsistencies between results obtained in clinical trials and in real world. And in order to, and this was the situation a few years ago, you can see that in Europe, the situation was pretty bad, as the improvement in visual acuity was not that expected in a clinical trial. So in order to reduce this gap, we may want to use a treat and extend regimen. And this is just to highlight that also in the COVID period there was a problem regarding the effective treatment in this patient. But one of the most important aspects is that we may want to use a treat and extend regimen, which can reduce the burden for patients, but with good effectiveness in getting good improvement in visual acuity over time. There are also some biomarkers associated with the worse visual acuity, and even in this case, deep learning may be useful to detect this biomarker, one of the most important, the presence of intraretinal fluid, which is associated with the worst visual outcome in our patients. Another important issue when we start treatment with anti-VEGF is the discontinuation of treatment in our patient. And it is very common to see patients quitting their treatment with anti-VEGF, which is not a good news, as commonly those patients quitting their treatment with anti-VEGF may have a worse visual outcome over time. So this is just to highlight our experience with the discontinuation of anti-VEGF treatment. We were able to demonstrate in this multi-center study that there are a number of reasons why patients may quit the treatment with anti-VEGF, including clinical decision, systemic disease preventing the patient from attending treatment, death, the patient choice to quit treatment, or the patient decision to continue treatment to another clinic. And what it was quite surprising to see that there are risk factors for these reasons behind the discontinuation of treatment. One of the most important risk factors was the time after starting the treatment. The clinical decision was very common in the first 2 years of treatment, which is not a good news, and this means that we need to improve our clinical decision when we quit treatment in our patients with neovascular AMD. But there are other clinical factors, including the visual acuity. Those patients with worse visual acuity were more commonly interrupting treatment with anti-VEGF. Of course, males were more commonly interrupting treatment because of death, or those patients with the worst visual acuity were likely less motivated to continue treatment. So this was another risk factor for the patient choice to quit treatment. So all these aspects are important, as we need to keep our treatment ongoing in patients with neovascular AMD in order to avoid the development of macular complications. There are different macular complications associated with neovascular AMD. The two most important are macular fibrosis and macular atrophy. Macular atrophy may be detected using multimodal imaging. It is usually visualized as an hypopigmented lesion on a fundus photography or multicolor imaging, as an hypoautofluorescent region on fundus autofluorescence. And when we look at the structural OCT, you can see this hypertransmission defect associated with the absence of RP and the outer retinal layers. Macular atrophy and fibrosis are very common in patients with neovascular AMD. There are some risk factors. First of all, it is important to remind that the incidence of macular atrophy is high. In 2 years, almost 30% of our patients with neovascular AMD may develop macular atrophy. And macular atrophy may be detected using structural OCT, as I mentioned previously. The main difference between macular atrophy and geographic atrophy is the presence of a neovascularization. This is just to highlight that the term macular atrophy is preferred when we have the presence of a neovascularization. When we have macular atrophy, there is a drop in visual acuity. So macular atrophy is a main driver in determining visual acuity in patients with neovascular AMD. But when we get macular atrophy, also the reading performance may be affected in our patients with neovascular AMD. We know that reading performance is affected in patients with geographic atrophy, so without any evidence of neovascularization, but it is also affected in patients with macular atrophy neovascular AMD. So let's say that you have a patient with neovascular AMD. Once there is the development of macular atrophy, which again is a common complication, this patient may have a worsening in reading performance. And also the topographical location of macular atrophy is important in affecting the reading performance. There are different pathways that may lead to macular atrophy. Geographic atrophy, we'll see geographic atrophy in the next few slides, is mainly associated with drusen or reticular pseudodrusen. Macular atrophy may be related to different pathways, including a mechanical damage to the RP. This is an example of type 3 macular neovascularization, the neovascularization causing a mechanical damage to the RP. Another pathway that may lead to atrophy is a collapse of a serous PD. This is another example of a type 3 macular neovascularization after treatment. The collapse of a serous PD may lead to the development of macular atrophy. And finally, macular atrophy may be associated with the development of fibrosis. When we want to make a diagnosis of macular atrophy, we may want to use different imaging modalities. Probably the most important is structural OCT, as other imaging modalities, including near-infrared or structural or unfast structural OCT, may be affected by the presence of different lesions that are quite common in neovascular AMD. So my suggestion is to use the OCTB scan to detect the presence of macular atrophy and associated fibrosis. Finally, before concluding this part of neovascular AMD and addressing geographic atrophy, there are some risk factors for the development of atrophy. The most important risk factor is the presence of intraretinal fluid, but also the diagnosis of type 2 or type 3 are two important risk factors for the development of atrophy. It is important to recognize that when we have a patient with AMD and some intraretinal fluid, as in this case, this doesn't always mean that there is a new vascularization. There are some vascular lesions, as in this case, named with some fluid inside, named microvascular lesions associated with AMD or drama that can be associated with the fluid. These are not new vessels, but are vascular abnormalities that similar to microaneurysm that may affect patients with AMD. Let's move to the last part of this presentation. Geographic atrophy is another form of late AMD. When you have a patient with geographic atrophy, you may want to use fundus photography or geographic or fundus autofluorescence or structural OCT to define and measure the region of geographic atrophy. On structural CT, the hypertransmission defect may be used to detect and measure the region of geographic atrophy. On fundus autofluorescence, the hypoautofluorescent lesions associated with the absence of RP may be used to measure the lesion with geographic atrophy. OCT is important, but also OCTA may be used in patients with geographic atrophy, as OCTA can detect some hypoperfusion around the region with geographic atrophy, which is associated with a faster progression of GA over time. There are several biomarkers associated with a faster growth of GA over time, including the RP2 Brooks membrane thickness in the border, the outer retinal layer thickness in the border, the presence of photoreceptor alteration in the border, and the presence of a choriocapillaris hypoperfusion in the border. So when we have a patient with GA, we want to investigate all these biomarkers in the border of GA in order to predict the progression, the growth progression over time. And also the presence of basal lamina deposits, as we have already seen in patients with intermediate AMD, also in this case are an important biomarker of progression over time. So in conclusion, and I will be happy to discuss with all the panelists and with all of you, and thanks again for this opportunity and for taking the time for attending this presentation. Imaging biomarkers are important in AMD. We must use imaging biomarkers to predict the development of late AMD or to predict the progression, the outcome, the visual outcome in patients with neovascular AMD. And so all these factors may be employed in our clinical practice for the best approach to our patients. Thanks again, everyone, and I'm open for the discussion. Thank you.
Yeah, thank you so much, Dr. Enrico, for this wonderful talk. Just to summarize, we had an amazing lecture covering the basic pathophysiology, the biomarkers, then the treatment regimens. You also spoke about the mismatch between the clinical trials and the real world scenarios, and in the end, complications nicely on geographic atrophy. So, I would like to ask you the first question related to the end part of your talk, that is related to geographic atrophy. That what is the current role of complement inhibitors? Like you also mentioned about pegcetacoplan and avacincaptad in geographic atrophy. And where do you see this field heading further?
So that's a great question.
Hello, can you hear me?
Unfortunately, I can hear you. Can you hear me?
Yeah, it's clear.
Okay, thank you. This kind of treatment is not approved in Europe, so we have not been able to build our clinical experience with this kind of treatment. However, I do believe that this treatment may be helpful in our patients, especially if we are able to define the different patterns of development of progression of GA. It will be probably important to define the different pathways and the different patterns in patients with GA in order to better understand which are the patients most suitable for this kind of treatment. It is also important to remind that this kind of treatment may be associated with some complications. I've seen recently some patients, not personally, I've seen some case series showing patients developing complications because of this treatment. So probably it is very important to use, it is very helpful to use this treatment, but it will be even more helpful to get the best treatment suitable for the treatment. But I would like really to have the opinion of everyone.
Yeah, Dr. Mona, Dr. Darius, your comments on the use of complement inhibitors in geographic atrophy. That was the question, Dr. Enrico. And yeah.
I think it was an excellent talk, Dr. Borrelli. Lots of information. I'm sure the audience would have enjoyed it. Complement inhibitors are not available in India right now. There are still concerns about it, and probably our incidence of geographic atrophy is probably not as high as the West, though with our population aging, we are likely to see more and more of it. So I think as far as we in India are, we're just watching what is happening and probably will have to take some lessons from it.
Yeah, I think I agree.
That's probably my take on it.
Okay.
There were some complications related to that. So I think we have to be very watchful and wary of that. And I don't know whether Dr. Enrico has any experience with any of the complications which happen with the complement inhibitors.
Actually, we have Dr. Ahmed Salam. I don't know if sir is on there right now, because someone from US can throw more light on the
Yeah.
personal experience.
Yes.
It's not yet approved in Europe. I had one question, Dr. Enrico. Like photobiomodulation is something which has started more in Europe, and Lightside 3, the results were out last year in December, published in Retina. So, how do you see photobiomodulation coming up as a modality for intermediate ARMD? Because while Valida, the machine, it's already out, and they say that the sessions need to be repeated. So, what is your personal experience with photobiomodulation, and how do you suggest its use in future?
Thanks for the question. So just to follow up to Darius' comment, I do believe that complications may happen in patients with treated with the complement inhibitors. Usually these complications are not common and are not associated with the worse outcomes in these patients. But of course, even the development of macular neovascularization or the thickening of the optic nerve. There are some cases with this thickening of the retinal nerve fiber layer, which is not really, which they were not really able to understand if it can be associated with any change over time. We really need to better understand which patients may benefit from this kind of treatment. Regarding photobiomodulation, we have some experience in patients with intermediate AMD. I do believe that this kind of treatment may be effective in improving mitochondrial function, which is well known to be affected in patients with AMD. There are some patients showing a reduction in the drusen volume, but I'm not sure if this is clinically relevant. The reduction in drusen volume does not always lead to an improvement in visual acuity. And we don't know if this reduction in drusen volume is also associated with a reduced risk of developing late AMD. So I have the feeling that this kind of treatment may be effective in getting some anatomical changes, but we need to further study this kind of treatment in order to understand if it can be clinically relevant.
Yes, thank you, Dr. Enrico. I would like to switch over to the imaging aspect now. You showed a lot of OCT angios in your presentation. I would like to ask a very basic question that how often do you perform fluorescein angiography, or when do you think fluorescein angiography is a complete indication, or is needed in what cases?
So that's a great question. And I will also love to have the insights of Dr. Cicinelli on this, as she's also an expert of multimodal imaging in patients with macular disorder. I must say that probably the most important imaging modality in patients with neovascular AMD or in patients with AMD overall is structural OCT. With structural OCT combined with OCTA, we can really be able in AMD to make a diagnosis of neovascular AMD in most of the cases. So probably in AMD, most of the cases may be managed by structural OCT and OCTA. Of course, there are some cases when we have, as an example, an aneurysmatical type 1 neovascularization, so a polypoidal choroidal vasculopathy, which is not commonly associated with AMD in Europe. It is more commonly associated with the pachychoroid disease in Europe. In this case, we can have some hemorrhage, and in these cases, I may want to use ICG and fluorescein angiography for the best diagnosis. There are also cases, and again, Maria Vittoria may want also to discuss on this, where we are not sure about the differential diagnosis between AMD and other disorders, including inflammatory disorders. In this case, when we are not sure if this is really AMD, FA and ICG may be important.
Thank you.
I think Dr. Maria and Dr. Shroff can also throw more light on this aspect. OCT angiography versus conventional angiography.
I totally agree with you, Enrico. What I'm trying to do, for example, in my clinic, and I try to teach the residents, is that where you are not sure, we are trying to get fluorescent angiography and ICGA at least at baseline to confirm the diagnosis. because sometimes you can have some masquerader. You correctly made the example of pachychoroid disease. So you know that the prognosis might be better. And if the fluid does not resolve, you may want to add photodynamic therapy. Or sometimes you have type 3 neovascularization, but you may miss on OCT because you just see some hyperreflective foci in the retina, and the OCTA is not conclusive, but you see the hyperfluorescent spots on fluorescent angiography and ICGA. So I still like taking it at baseline.
I think that's a very important point. I also agree with Dr. Maria that at baseline, we like to do this also for any cases which may be AMD mimics or where you're not sure there's a CNVM. Those are the cases we look in deeper and use these modalities. And there's, in fact, interesting cases where we have vitelliform disorders, sometimes which have a network. And I think this is one situation where I found Octa to be more useful than FFA. Because in fluorescein, you just see some diffuse kind of leakage. But with Octa, you can pick up the network. So this is one situation where I found Octa better than FFA. But generally, I agree at the baseline, it should be done. And wherever you have a doubt, you should go in for the invasive modalities.
Agree.
Dr. Rupak, sir, can you give your quick comments on how often do you require manual segmentation in Octa? And how often do you feel projection artifact can cause some confusion about the presence of neovascular network?
Dr. Rupak, you're muted.
Yeah, so as everybody said, OCT angiography has assumed a lot of importance nowadays. Two aspects I was asked. One was the projection artifact. Now, thankfully, most of the modern machines have this setting where you can have it projection artifact removal. So that should be kept on all the time. And with the modern machines and the modern technology, the amount of projection artifacts that we see have really lessened nowadays. So that is one part about the projection artifact. Manual segmentation is very important because if there is a small membrane, so if I am not able to, if in a structural OCT I'm able to see a subretinal fluid, I am able to see a double layer sign, and I'm expecting a network and I don't see a network, so obviously I would go back and do a manual segmentation. If I'm able to see by the default slab, I'm able to see the OCT, the membrane network, then it is okay. But I think manual segmentation is a very important armamentarium for any clinician, and it should be done all the time when you really see a OCT angiography.
Hi, Dr. Borrelli. Great talk, great presentation. I would like to follow Dr. Rupak, and you nicely showed that sometimes we can clearly appreciate a splitting between the RP and the Brooks membrane, and sometimes we can clearly see basal laminar deposits. But in the setting, for example, of geographic atrophy, sometimes the double layer sign or the CIRE or this type of sign sometimes can also suggest neovascularization. So from your clinical perspective, is OCT enough? Is OCTA needed for this to distinguish between basal laminar deposits or just neovascularization? Sometimes this double layer sign can present as a thick double layer sign or thin double layer sign according to reflectivity. But what do you think?
No, that's an important point. I do totally agree that the double layer sign and this flat PD may be associated with either neovascularization or basal laminar deposits. The thickness, as you nicely mentioned, may be important to differentiate between basal laminar deposits and neovascularization, as usually this flat PD with a double layer sign is thicker in the presence of neovascularization, but this is not always the case. So in this case, it is always important to have a multimodal imaging approach, and in this case, it is mandatory to perform OCTA in order to investigate whether there is any flow within this flat PD.
I think Dr. Muna, you have a comment, madam. You're mute.
Just a comment on the use of fluorescein angiogram and ICGA as first line. I think if we give, very often you find the fluorescein angiogram is not done the way you want it. Either the quality is poor or the wrong eye was done first. I think if we want to make these tests useful, we have to be very clear what we are asking for. Do we want the right eye first? Do we want the left eye first? Do we want a 30-degree picture? Do we want a wide angle? Do we want a 55-degree? Because the advantage of Octa is repeatable. If you don't get what you want, you can always go back and look at it. But if you do a fluorescein and an ICG, which is a great expense for our patients, and your instruction or the area of interest is not clearly mentioned, especially when you have a technical team doing it separate and you're not doing it yourself, I think there's a lot of scope for missing important findings and losing the information that you want to get unless you are very clear about what you want. So I think that way Octa has a benefit where, if you don't see something, you can always go back and do it. Of course, you need to spend your time and you need to invest a little more in terms of your time and effort in segmenting, looking for the area you want. But that's one investigation. You can always go back without having to do another dye injection or anything. So that is one possible benefit of doing Octa the first time.
One more question, ma'am. Like often we come across cases where one eye has scarred CNVM and the other eye apparently appears normal. How deeply would you like to investigate the other eye in such cases with multimodal imaging?
Yeah, I would do it, especially with a type 3 MNV in one eye, because we know the risk of fellow eye involvement within a year is almost 70 to 80%. And these lesions are extrafoveal to start with. So you have to do a very careful examination, take a good clinical photograph, look at the entire area. You may see a small retinal hemorrhage somewhere that you may miss, and then do your Octa carefully. Scan the entire area with your B scan, and then if in doubt, do an FFA or ICG. We must remember that very early RAP lesions are not picked on an ICG, so an FFA would be more helpful in those cases.
Okay. I think again I'm going to switch gears from investigative modalities to maybe a patient-centered question. Dr. Borrelli, you spoke about the compliance of the patients, and during COVID years where we missed out, or if the patients are unable to reach us, and we see a very range of complications and vision loss which happens. So, how do you see this long-acting anti-VEGF agents like cefarizumab or brolucizumab, or even the port delivery system, changing our approach to neovascular AMD cases?
So thanks for the question. I think this is a very important point. The treatment burden for patients is a major issue, even for clinics. Not only for patients, but also for clinics, we need to reduce the treatment burden. And so these new drugs with a longer durability may have a significant impact on the treatment burden in patients. It is not uncommon to see patients with a low visual acuity who are not motivated to keep treatment ongoing. And so in these cases, reducing the number of treatment or changing the way we deliver treatment may be helpful in reducing the treatment burden and so improving the motivation of our patients. And I do believe that these new treatments, the faricimab and aflibercept 80 milligram, have something different as compared with treatments in the past. They are longer duration, they are safe, And so we are very confident when we start our treatment with this drug, and so we can get a long duration and we can reduce the treatment burden for our patients.
How promising do you think the gene delivery system is going to be in the time to come? Like aflibercept gene has been shown to have some promise.
I've seen some results from clinical trials which are very promising. And so I don't know if how many of these treatments will be available in the future, but I do believe that any treatment that can reduce the treatment burden for patients is more than welcome.
Maybe the next question is to all the panelists that what do you think will be the biggest paradigm shift in the treatment, in the management of AMD, both geographic atrophy, dry and wet, so in the next 5 years or so? Maybe Dr. Rupak would have to start.
Yeah, for me, the biggest paradigm shift I would think is development of more longer acting molecules, and maybe targeting the other pathways that give rise to exudation and fluid, because we know this anti-VEGF is a trusted pathway. We have been able to block it, but there are problems with it, as we have discussed, that repeated injection, multiple patient visits. So, I mean, if we can look beyond it, looking for a promised molecule which can give us a longer lasting effect, targeting a different pathway may be the way forward. Geographical atrophy, I think there was a lot of excitement around pegaloctapan, but now we have seen the results are not great. And also there are some of the patients did have some complications. And in a setting like ours, I don't think that kind of treatment is very effective. So I'm not really thinking too much of GA at this point of time. But neovascular AMD, yes, I think looking the quest towards a better molecule is the future.
Yeah, Dr. Darius and then Dr. Alberto on the similar lines of question.
Yeah, I think with our kind of patient population, we have to be realistic. The GA therapy, like Dr. Rupak said, where you're just slowing down the progression of the disease, but you aren't showing any improvement. That is not going to be very viable in our scenario. And also monthly injections for something without any endpoint. So I think that is still a long way to go. And definitely we're looking at different molecules, tyrosine kinase inhibitors, the new RGX gene therapy. I think all these are in the pipeline. For me, I think the durability is the most important, because patients can't come back so easily. The caregivers have to take leave from work. So I think these are there in all parts of the world. I think Dr. Enrico, Dr. Maria, Dr. Alberto, everybody. So I think if once we get the durability longer, it will be good. We already have faricimab in India, but we don't have 8 milligram aflibercept. So that is something we are looking forward to in our population.
I completely agree with the other panelists, and as the Pulsar trials show previously, also the fluctuation of the fluid matters. So long durability of the molecules is an important point, and linked to this point, maybe HOMO-CT can change the clinical practice, since the HOMO-CT, there are trials, there are many studies that are ongoing. Maybe HOMO-CT can better can better characterize the fluctuation of the fluid, and maybe also better clinical outcomes. So
Can we have the comments from Dr. Dr. Maria, can you let us know your view?
Yeah, I mean, I think that one of the most important paradigm shift, we already had it, that was shifting from reactive, so like a prorenata, we have changed completely our mind in the last 10 years, that is proactive. So it's preventing the reactivation. So everything that can prevent any activity or exudation and hemorrhages can really change the prognosis. So again, this drug or other pathway as those, for example, in the future that also tackle fibrosis may be very, very useful.
I think on similar lines, we have an audience question as well. There's a question from Dr. Anubhav Upadhyay. He's asking that in the long run, with multiple anti-VEGF injections, eventually patients end up with suboptimal vision gain because of subfoveal scarring. How to manage the same, and what is the effect of newer molecules on the scarring component? This is Dr. Enrico and the panelists.
So that's a very good question. As Maria Vittoria already mentioned, one game changer could be a treatment to also reduce the development of fibrosis, or also to tackle the presence of fibrosis. At this moment, we don't really know if these new drugs may be more effective in reducing the development of fibrosis. Faricimab seems to be associated with some anti-inflammatory effects, and so it might be important to reduce the development of fibrosis, but there are no evidences of this. The most important aspect I would suggest is to reduce the number of fluctuations of fluid over time. There are some evidences suggesting that fluctuations may be associated with the development of atrophy or fibrosis. So if I have a patient, I try to reduce the number of fluctuations over time, and a longer duration of treatment may also be useful for this in order to reduce the rate of development of these two types of complications.
So, Dr. Enrico, apart from AREDS2 criteria, do you also suggest something like high-dose statin for intermediate ARMD? High-dose statin.
I don't use this type of therapy in my patients. But there are some evidences suggesting that it can be useful, but I don't have a large experience on this.
Muna Bende, ma'am, what is your, the most of the drugs in India, they don't follow the AREDS criteria. So do you usually advise medications which strictly adhere to the AREDS criteria? And additionally, do you advise any other medication for stopping progression or reducing progression in intermediate ARMD?
I would go with what goes closest to the AREDS criteria. And we have a lot of our patients who have children who live abroad. So sometimes you can get I encourage them to get the exact AREDS formulation, because a large number of our patients have children who live abroad. So it's fairly easy to procure that out of over the counter. So that's what I do. But I would always go closest to the AREDS criteria and not prescribe anything else. And only in high-risk AMD, not if there are two drusen or something. Because a lot of people have tummy upset due to the zinc content. So I don't force it on a patient. I tell them if you don't tolerate it, don't take it.
I have a question. How do you manage a patient with neovascular AMD and cataract? All of you, do you wait for stability, or do you go for surgery and maybe add some additional anti-VEGF?
I think we'll start with Dr. Darius. Your take on that?
I think it's a wonderful question and something which very practical because we face it all the time. So of course there would be a lot of factors to kind of look into, but if I feel there's a lot of exudation, a lot of fluid, I may stabilize the patient, give them like 2 injections. And what I always do is at the time when I give the third injection, within 5 to 7 days, I'd have the cataract surgery done. So I would feel that the cataract is being done under the cover of the anti-VEGF injection. So this is what I practice in my clinic.
Totally agree.
Any other faculty who would want to comment on that, or Dr. Munawende, your experience on that?
Yeah, suppose the cataract is not very significant, then I would prefer to stabilize the eye before I do anything. We often have our patients who develop cataract in the course of treatment. In those cases, I would give the injection along with the cataract surgery at the same time. But in case I'm not able to assess at all because cataract is too dense, then maybe I would suggest cataract surgery and immediate reevaluation and start the treatment.
Here in US, actually, we see the patient, we try to stabilize before cataract surgery, but we see also on the cumulative amount of the injection before cataract itself. So if the patient has also a huge amount of intravitreal injection in his history before cataract surgery and has no subretinal fluid, we would like to see more stabilization. So we go for another injection before cataract itself, because sometimes, despite stability, the patient can exudate as well after the cataract surgery. So we decide for another injection before cataract.
May I have a comment? I think it is also important to keep in mind that an history of anti-VEGF treatment is a risk factor for complicated cataract surgery. So it is always important to know if a patient has a history of anti-VEGF treatment, because sometimes the surgery can get complicated.
I just want to make a point. This is a very interesting discussion and very pertinent one. In a situation like in our countries, where the patients are not always motivated to undergo multiple injections, loading dose, then multiple injections, and starting that patient, if the patient has a sort of significant grade of cataract and with a active macular neovascularization, sometimes and not very great amount of fluid, sometimes I may start the patient with cataract surgery and anti-VEGF so that the patient also has some improvement. Otherwise, in a very dense cataract haze, if you give an injection and you keep on telling the patient that I'll give 3 more injections, then we'll assess. And in a situation like ours, sometimes the patients lose motivation to continue treatment. So sometimes the visual benefit sort of spurs the patient to undergo more treatment and stay adhere to the regimen. This is a practical point. With some patients, I have seen this work.
Can I ask a question?
Yes, please.
Yeah, so again, something which always troubles me, like recently I had a young lady with a CNVM and she turned out to be pregnant. So first trimester. So what would everybody do for such a patient? She had angioid streaks and a CNVM, or it could be myopia, high myopic CNVMs. Dr. Enrico, any protocol you follow?
No, I was thinking about your question as this is a very challenging question. I had experienced a few patients with CMV developing during pregnancy, and in those cases, I wanted to avoid the patient to be treated. However, there is no protocol in Europe in these cases. But it was not a very challenging. I didn't experience a challenging situation, as no patients with unilateral, bilateral disease or other factors that may affect bilateral visual acuity were raised in our clinic. But this is a very challenging situation. I'm not sure which is the best practice in this case. but in the experience we had, we didn't want to treat the patient.
Dr. Mona had a comment, I think.
Yeah, probably being older than most of you here, I have a little experience of the pre-anti-VEGF era. And, we've had patients when we used to treat with transpupillary thermotherapy. So then pregnancy was not an issue. So you just did your focal treatment and managed it. There have been times when there is a lot of exudation. You can even consider a steroid injection just to bring down the exudation temporarily. Otherwise, these changes do occur because of the VEGF surge during pregnancy. You expect that any dormant CNVM can also grow. Luckily, myopic CNVMs are small and sometimes they stabilize. So by the third trimester, maybe you can plan an injection.
Since we are talking about safety, nephropathy is something which is again coming up as a relative contraindication, especially by the nephrologists for anti-VEGF use, intravitreal anti-VEGF use. I think Mona ma'am, you had some articles to share in PRSI group in this regard. So, what do you really feel? Is nephropathy contraindication or a relative contraindication, or were the reports just anecdotal reports of nephropathy worsening due to anti-VEGF agents?
Well, we've heard people talk about it. Personally, most diabetic patients with DME, many of them have pre-existing nephropathy. So if they already have nephropathy or borderline renal function, I just keep the nephrologist in the loop and say that this is what we want to do. And I think the most concerns are for aflibercept. So in these patients, I would opt for ranibizumab, which is, in even that controversial article, it is mentioned that probably you can consider ranibizumab. Of course, if a diabetic macular edema, then you treat them with steroid. But to have a patient with nephropathy and AMD is going to be a little rare. So I think in those cases, you can choose a shorter acting anti-VEGF. This question usually comes for diabetic macular edema rather than AMD.
So, Dr. Darius, what do you think will be the safest anti-VEGF agent for you?
So I think there's not too much data, but from Sailor study, there was subgroup analysis and they said 0.3 milligram of ranibizumab, which Dr. Lucentis, which was that time what they were using in India also. So probably I would also go in for ranibizumab for such a patient. And initially we were giving a little lower dose. I don't know whether that was really justified, but maybe a half dose of ranibizumab. Somebody who's really critically ill in those cases. And as they were generally for these are diabetic patients who generally present like this.
Dr. Enrico and Dr. Darius, how do you go ahead and all other panelists, how do you go ahead with a large submacular bleed complicating a case of wet AMD?
I think it depends on the size of the bleed. If it's really huge or very, very large, then we really may need to go for a surgical intervention. But lately, I've been seeing that these, if they're moderate in size, you can do quite well with just displacement with a gas bubble, TPA, and anti-VEGF. And since in our Indian population, most of these are because of PCV, I think aflibercept works well. Other thing is that sometimes you can even get away only with anti-VEGF. I think we can take Dr. Rupak's comment and Dr. Muna's also, because only anti-VEGF therapy in certain patients who are not willing to position with gas also works pretty well for these bleeds under the submacular bleeds, provided they're not very thick. What about the other panelists' experience on this?
I totally agree. It is also dependent on the time in between the development of this hemorrhage and when the patient is referred to our clinic. We may want to use surgical treatment in many of these patients, but when the hemorrhage is small and it doesn't affect the foveal region, we can also go with anti-VEGF.
So what I feel is that from small to moderate side hemorrhages, which are submacular, I think my personal experience has been great with anti-VEGF and just a pneumatic displacement. It is not very often that I've used TPA, and if you're talking of very large size hemorrhages, I have had experience with surgical management of those hemorrhages. So personally, what I feel, the surgical management in the immediate post-op period, you see clearing of the hemorrhage, but over a period of time, I have seen the patients developing a lot of RP atrophy, and I really doubt the robustness of the surgical approach. Though there are cases where obviously it is indicated, where you think nothing else will work. But from small to moderate hemorrhage, my go-to therapy will always be a pneumatic displacement with an anti-VEGF. As Dr. Daraz said, that sometimes only anti-VEGF tends to works fine. So it's anybody's choice. I think whoever is comfortable with which approach should take that. And also other considerations should be taken into account: positioning of the patient, whether the patient is able to position, because these are elderly population. So those things should be kept in mind.
Dr. Mona ma'am, what's your go-to method for a large submacular bleed complicating wet AMD?
If it's a large subretinal bleed, then I would just prefer a pneumatic displacement, because I've found it works. It's easier on the patient and not more than a couple of days of prone positioning and it goes away. Of course, if there is a diagnosis, then I will give anti-VEGF at the same time. Very limited experience of TPA. I've used it a lot in the past, but very rarely suggested now. And I think like Rupert, probably that would be my first choice, just a gas bubble and an injection.
Dr. Maria and Dr. Alberto?
I think that these are all good points. We have always to consider if the bleeding is just subretinal, but we should also take into account that sometimes the bleeding could be also intraretinal. So we should consider if a pneumatic would be effective in these cases. So beyond the location, beyond the age of the bleeding, we should also consider the location within the retina or just under the retina. So maybe in these cases, anti-VEGF could be suggested.
And we do not have a very large case series in our center with the blood displacement, but one piece of advice to any resident or fellow is when there is a huge hemorrhage is something that we want to exclude in also an RP tear, and that can also affect the long-term prognosis. And then I don't know how worth would be doing a displacement if there is a huge tear and a huge hemorrhagic RP tear. So this is not another thing to consider when you assess a patient with large hemorrhage.
Also, sub-RP blood will not displace. So it has to be subretinal if you're planning to displace.
So we have had a thorough discussion today on various aspects of ARMD. I would like to ask if any of the panelists would like to add anything else to the discussion before we close. So if there are no more comments, I would like to sincerely thank Dr. Enrico Borrelli for taking out his time and enlightening us with his wonderful talk on various aspects of ARMD. Biomarkers is something which is not much emphasized often by clinicians, but we could see from your talk that there are so many biomarkers which can help us and which can actually help us prognosticate the cases and guide patients better. Also, we had a good discussion on various imaging modalities, the future of ARMD with some deep learning based algorithms coming up in future, which can guide us better in patient care. There were excellent points, clinical points, and pearls of wisdom given by our senior faculty members, by our various panelists. So I would like to thank all my panelists, senior members, Dr. Mona ma'am, Dr. Dalal Shroff, Dr. Rupak sir, Dr. Maria and Alberto. Thank you all for taking out time and enlightening us with your clinical experience. We would like to see all of you time and again in various of our upcoming classes and sessions. And please do keep joining us time and again. It was a great learning experience. This online session would be live, would be available online, and we shall share the link. And I'm sure a lot of retina specialists from across the globe will benefit by going through the detailed discussion which we had. Thank you, everyone. We hope to see you all again in our upcoming future ASG international some online classes. So good night.
Thank you.
Thank you.
Yeah,
Thank you.
Thank you.
Thank you.
Good night.
Thank you for the opportunity. Thank you.
have a nice day, the ones in US and Europe.